Welcome back to our final session on our 2020 Patient Family Conference, an overview of novel therapies for thalassemia, which will be presented by Dr. Sujit Sheth. Sujit Sheth is currently Professor of Pediatrics and Chief of the Division of Pediatric Hematology and Oncology at Weill Cornell Medical College. He is board certified in his specialty and has 24 years of experience post-training. Dr. Sheth's area of interest and expertise include red blood cell disorders such as thalassemia, sickle cell anemia, spherocytosis, disorders of iron metabolism such as iron deficiency and iron overload, and bleeding and clotting disorders like hemophilia, thrombophilias, etc. After completing postdoctoral training, he spent 15 years on the faculty of the Columbia University Medical Center in New York before assuming a leadership role at Weill Cornell. In his current role, Dr. Sheth is director of the Comprehensive Thalassemia Center with one of the largest single-center cohort of thalassemia patients in the United States and oversees a New York State designated Hemoglobinopathies center. Dr. Sheth?
Thank you very much, Craig, for that kind introduction. And I also want to extend my thanks to the Cooley's Anemia Foundation for inviting me to participate in this conference, which I think is year after year getting more and more interest, and with all of the developments that are happening in terms of the therapies, getting more and more complicated and more topical. So without further ado, I'm going to talk about novel therapies. These are my disclosures. So I think as we talk about the novel therapies, I think it's important also to just keep in mind the context of thalassemia and what happens in thalassemia so that we can really think about where these therapies are targeting their effect so as to ameliorate some of the effects that thalassemia has on an individual's body. So basically what you see here is the development of normal red blood cells. So you know that normal red blood cells are made in your bone marrow, and inside each normal red blood cell is hemoglobin, and hemoglobin is what transports oxygen to the tissues. Now, hemoglobin contains alpha globin and beta globin, which is present in equal amounts. And if you have thalassemia, so if you have beta thalassemia, then you don't make beta globin normally. And so you're not able to make normal hemoglobin, and that results in abnormal red blood cells or fewer red blood cells actually being produced. So what you see here is in the early stage of red blood cell production in the bone marrow, you start out with stem cells. These are the most primitive cells that can make lots and lots and lots of daughter cells. And that the first phase that happens is the proliferation phase, wherein you have division of those cells and the production of more and more of these precursors. At some point then, these cells go into what we call a differentiation and maturation phase, at which point hemoglobin starts to be produced inside those cells. And when they're fully mature, these red blood cells come out of the bone marrow into the blood circulation, and then they're able to do their function, which is transporting oxygen in the body. Now, this is what happens with thalassemia. So your stem cells are normal, and they undergo proliferation, and the problem is that they don't undergo differentiation and maturation normally because there's a block here. And what happens essentially is that because you don't make beta globin normally, there is an abnormal precipitation or the formation of aggregates of globin that then result in damage to those precursors, preventing them from maturing normally. And then these cells kind of tend to die out in the bone marrow itself, and then very few red blood cells are produced as a result of that. And as a result, there's very little hemoglobin in those cells, as you can see here, when they come out of the bone marrow. So keep this particular figure in mind, where this block is at the point of differentiation of the red blood cell precursors. And this is just an overview of all of the different things that happen in thalassemia. It's a very busy slide, and I'm not going to go through all of them. But keep in mind here, you see ineffective red blood cell production in the bone marrow is a very central part of what happens in this condition. And as a result of that, you have most of these other complications like expansion of the bone marrow, enlargement of the liver and spleen, the anemia that results because fewer red blood cells are coming out of the bone marrow, the requirement for transfusions, the development of iron overload, all the possible complications that can happen as a result of the iron overload, and then other problems like blood clotting and the formation of ulcers and pulmonary hypertension and things like that. So all of these things are what happen with thalassemia, and therefore we have to intervene, and a lot of individuals require regular blood transfusions, which then results in iron overload as well. Some who don't require regular blood transfusions may have other kinds of complications, mostly related to the thalassemia itself affecting their blood vessels. Now, I'm not going to go into all of the details of treatments for thalassemia or conventional treatments for thalassemia because you're already undergoing these treatments. What I'm going to summarize is the fact that we've come really a long way in thalassemia treatment over the last 2 or 3 decades. We have a much improved safety of the blood supply. As you know, we do extensive testing on blood donors and the units of blood that they generously supply. And as a result of that, the transmission of infection through blood has gone down quite a bit. In fact, it's so rare now to have transmission of infection that we're really happy about that. We're also doing a lot of extended typing. We're typing the red blood cells much more accurately. And this has resulted in a reduction in the incidence of people who have developed antibodies. So some of you may have antibodies which have resulted over the years from getting units of blood that may not have been absolutely perfectly matched to you. And then that makes it very complicated in terms of being able to get appropriate blood. And so we've instituted this additional testing, which allows us to minimize the development of these antibodies. Obviously, oral iron chelation is a huge step forward, moving away from the subcutaneous infusions of desferol to now taking oral medications to chelate the iron is a huge step. We've been able to monitor iron overload much more accurately through MRIs to be able to individually tailor the treatment regimen of what chelation you get. We have improved management of hepatitis. And then stem cell transplantation, which is currently at least the only curative way of treating somebody with thalassemia. We have improved the way that we are able to do this stem cell transplantation tremendously. And so the success rate of transplant is much higher than it used to be as well. However, there are still some things that we are not able to completely do, and that is we don't really have a curative option for those individuals with thalassemia who don't have a matched related donor to be able to give them the bone marrow for the transplant. We're not able to do a whole lot about the ineffective red blood cell production that happens in the bone marrow that I described at the start. We're not really able to prevent iron overload and its complications so well. We're able to prevent its development by chelation, but we're not able to really do much to reduce the amount of iron going into the body as a result of the transfusions themselves. We're able to treat bone disease a whole lot better than we used to be able to do, but we still have individuals who develop bone disease. And, you know, as all of you are aware, it's pretty cumbersome to go through living with thalassemia in terms of going to the hospital frequently, getting your transfusions, going for MRIs and other testing, a lot of doctor's appointments, and so a lot of frequent visits to the hospital. So all of these things we need to try and ameliorate to improve the way that we manage thalassemia. So what I'm going to talk about is some of these agents. So luspatercept, which is now approved, and it's called Reblozyl. We'll talk about gene therapy and gene editing and some of the results of the clinical trials. And then I'll just mention these other agents which are in early clinical trials: hepcidin mimetics, the pyruvate kinase inducer, and something else that interferes with the or modifies the energy pathway of the red cell production. So one of the things that I did mention, to go back here, is that what happens here when these red blood cells are not maturing normally is also that because you have these abnormal things that are precipitating or depositing in these red cells, they're not able to manage manage their energy metabolism very well. So they're ineffective in being able to breathe, as it were. So even the cells that are in development need to breathe, right? So they need oxygen as well, and they're not able to utilize this oxygen very effectively. And that also contributes to some of these cells not surviving and making it out of the bone marrow, all as a result of the imbalance between the globin chain production. So we'd start with luspatercept. And what luspatercept does is that it's able to promote that differentiation and maturation. So if you recall, there's this block when you have thalassemia that prevents the proliferation stage from then progressing into the differentiation and maturation stage, right? So if you're able to remove that block, maybe the red cells that are developing in the bone marrow may actually be able to mature better and then come out of the bone marrow in greater numbers, and that would make a big difference in terms of ameliorating the anemia and providing you with more hemoglobin to be able to transport oxygen. And so that's what luspatercept does, is it removes this block on differentiation. And as a result of that, the early studies showed that it improves the hemoglobin level in non-transfusion dependent patients. So if your hemoglobin level was 7 or 7.5, now you could get to maybe 8.5 or 9 as a result of being on this drug. And in patients who were on regular blood transfusions, you could actually reduce the amount of transfusion they needed, and thereby reduce the amount of iron that was going in as well, and maybe reduce the frequency of their transfusions as well. So this was the early data, and as a result of this positive data that they got, they conducted this study called the BELIEVE study. And that was a very large study of about 330-something patients with thalassemia. And they were randomly assigned to a treatment group with luspatercept or a placebo group in a 2-to-1 ratio. And the study went on for about a year. The primary endpoints were to see whether or not you could have a 1/3 reduction in transfusion burden of at least 2 units of red blood cells in a very specific 12-week period out of that 48 weeks of the study. And then similarly, they also had secondary endpoints, which were a reduction by 1/3 in any interval, or a reduction of 50% in any interval as well. So they looked at a whole bunch of different parameters at different time points as well. And these were the results. So the study met both its primary endpoint as well as the key secondary endpoints as well. So all of those endpoints were met. We did see a reduction in transfusion requirement by 1/3 in the specific time interval, but also at any 12-week or during any 24-week period during the study as well. And then the other question that comes to mind is, so that's all very well, but is it safe, and what were the side effects? And it was generally very well tolerated. Very few people had to come off the drug because of side effects. The main side effects that individuals had were some bone pain and some joint pain. And then the only serious complication, which occurred in a very, very small number of individuals, was the development of blood clots. Now, keep in mind that these individuals all had other risk factors for developing blood clots as well. And so what contribution this had, we're not absolutely clear about, but we did see an increase in blood clots in the group that got luspatercept compared with placebo. There are studies that are ongoing with luspatercept. So there's a study that's ongoing in non-transfusion dependent patients. Keep in mind, BELIEVE was only in transfusion dependent patients, and it did not include children. And so that's another study that's ongoing. Children with thalassemia are also being treated with luspatercept. And then the subjects who were in the belief study are continuing to be followed over time on the drug. And we're looking to see that to make sure that the effect of the drug is continuous and it's durable, and that no other new side effects are noted as these individuals continue on the drug. So let's talk about and I'm sure there'll be lots of questions about this later. But in the real world, once it was approved in November of last year. This is currently approved only for transfusion-dependent adults. So you have to be 18 or over, and you have to be getting regular blood transfusions to be able to get this. As I mentioned, we don't have data in children as of yet. We do have data now that shows that it does work in patients of different ethnicities from different parts of the world, as well as with different genotypes. So that includes individuals with beta 0, or beta 0, beta plus, or beta plus, or also those with E beta thalassemia. So in all of the subgroups, depending on the genotype, as well as depending on your ethnicity or what part of the world you're from, all of these individuals had significant response rates compared with the placebo group. However, the other thing that we must keep in mind is that if you already have significant bone pain, that this may make that worse. So that's something to keep in mind when you're thinking about whether this is right for you or not. And then the other side effect that I mentioned also, which was the development of blood clots. So that's also something to keep in mind. And so individuals with thalassemia who have other risk factors, we have to be very careful when we are talking about using luspatercept as well. In general, however, our experience has been that insurance companies are approving for the most part. Sometimes an appeal is required, but for the most part, they are still getting approval for it. So that's luspatercept in a nutshell, and I'm sure we'll answer some questions later on. Moving on to gene therapy, the approach has been twofold. So as you know, in thalassemia, the basic problem is that the gene that encodes for beta globin is not functioning normally, right? So what you can do is you can either insert a gene that does work, or you can try to correct the defect in the gene itself. So the first approach is called gene addition, where you're simply adding a gene. And this is done using a viral vector, which then integrates into the stem cell, and the gene of interest, in this case the beta globin gene, is inserted into the stem cell. Or you can insert a hemoglobin F or fetal hemoglobin gene as well. So you can either add a gene to make more normal adult hemoglobin, which is called hemoglobin A, or you can add a gene that makes more fetal hemoglobin, which is called hemoglobin F. And then you can also do gene editing. And this uses some newer technology to sort of splice out or in a gene of interest. So what we can do is we can actually inactivate a gene called BCL11A. BCL11A is responsible for silencing fetal hemoglobin production, right? So if you can't make fetal hemoglobin in adequate amounts, then you can't compensate for not being able to make normal hemoglobin A in adequate amounts. So if you can inactivate this BCL11A, then you can allow more fetal hemoglobin to be produced. That will increase your hemoglobin level, and that might reduce your transfusion requirement or make you transfusion independent as well. And we'll see some very interesting data related to this as well. And then the hope might be that you can also use this technology to correct the mutation. So you can splice out the mutation and put in the correct gene that you need to have in there as well. Now, this is how gene therapy works. So essentially, we are trying to get your stem cells. We stimulate the stem cells to come out of the bone marrow using a drug called pyrexafor. These stem cells are then collected through what we call pheresis, where the blood goes in, your blood goes into a machine, and these specific cells are then collected. They're then taken to a laboratory where the vector is then put in, the vector with the beta globin gene is put in, or with the gamma globin gene for that matter, or where the gene editing occurs as well. And then these modified stem cells are then tested extensively to make sure that the gene is in there and it's expressing and stuff like that. And then when all of this has been done, the individual is then brought into the hospital, is given what we call bone marrow conditioning, which means that you have to get some chemotherapy that will reduce your own bone marrow activity. It will kill off some of your abnormal functioning cells to make room for these new stem cells, your own stem cells, which have been corrected, to be put back in. And so this is done, and then the cells are then infused back in either directly into an IV that goes into your body, or they're introduced directly into the bone marrow itself, which I will tell you about in one second. So these are the studies that have been done to date. There's lentiglobin BB305. This is the vector that is being used by Bluebird Bio. And you have their North Star trials in thalassemia, and I will mention again the early trials, which are 204 and 205. And then I'll also mention the later trials, the more recent ones, which are 207 and 212. And then in Europe, you have this also lentiviral vector called the GLOBE vector. And this is still in an early phase study, and we don't have that much data from them as of yet. It's only been used in about 9 patients, I think it is. So I won't go into much detail about that, but that's the vector which is put into the stem cells, and then the stem cells are given directly back into your bone marrow itself. So that's the GLOBE vector. But then you have 2 gene editing studies. You have, and they're both in early phase. When you have phase 1 and phase 2, those are early phases of the study. And so the first one is called the Thales study of ST400. This is, again, very early. We have very little data from this. And then we have the phase 1-2 study of CRISPR-Cas9. And this is a vector, the process is called CTX001. And I will show you some very promising data, but very early data in 2 patients who have undergone this already. So first with lentiglobin BB305, these are the Bluebird trials, and these are the early ones, the 204 and 205. And just suffice it to say, just follow my little arrow if you can see it, yeah, here, to say that 12 out of 13 patients who had non-beta 0, beta 0 became transfusion independent with hemoglobin levels that were in the range of 9 and some to about 12 and some. And 3 out of 9 patients with beta 0, beta 0 became transfusion independent as well. So you can see that these are the results from the early studies. And in those patients who did not respond, who did not become transfusion independent, so they did respond, but didn't become transfusion independent. And you can see here what the dark green bars show is your transfusion requirement before gene therapy, and the light green bars show your transfusion requirement after gene therapy. So you can see that even in the patients who did not respond, who did not become transfusion independent, you did have, for the majority of them, you had a significant reduction in the amount of transfusions that they required as well. So those are the early studies, 204 and 205. And this is what you see in the later studies, 207 and 212. So what the company did was it refined its manufacturing process for the vector and the whole process around the transducing of the vectors into the stem cells, and made it much more efficient. And so here you can see in the 207 study, which is in non-beta 0, beta 0 patients, 18 out of 20 patients became transfusion independent. So you can see here The light blue is where you still required your transfusions, and then the dark blue is where you became transfusion independent. So these patients have been followed now for almost 3 years out, and you can see that that patients, the majority of patients, 18 out of 20, have become transfusion independent. This one patient initially became transfusion independent and then had to go back on regular transfusions, and one of these patients is still early, and it's still early to say whether they're transfusion independent, completely transfusion independent or not. The other thing you can look at is that with this refined process, the hemoglobin levels are generally higher as well in these individuals compared to the individuals in the previous study, where you see the hemoglobins are in the 8s and 9s and 10s. Here you can see that patients had hemoglobin levels in the 12s. And then also in the patients who had beta 0 thalassemia, 11 out of 12 patients here also became transfusion independent. And you can see this one patient here still who is on regular transfusions, has not yet become completely transfusion independent. And here too, you can see that the hemoglobin levels in general are a little bit higher, so 13, 14, 10, 11, compared to the previous study where you had somewhat lower hemoglobin levels over there. Okay, so these are the updated results from the Bluebird trials. And then this is the preliminary result from the CRISPR trial that I mentioned. This is the gene editing trial where you are affecting the BCL11A gene, and you're allowing the individual to make more hemoglobin F, or fetal hemoglobin. So 2 patients have been treated on this, and this is a very complicated slide. I would just focus on this figure on the bottom right of the slide. 2 patients, both of whom were non-beta 0 individuals, and you can see that the first one is now 14.2 months transfusion free with a hemoglobin level of 14.2 as well. And the second patient is now 3.5 months transfusion free with a hemoglobin level of 12.5. So you can see that these 2, and this is still early, that these individuals did have a response to the gene editing as well, and they're making more fetal hemoglobin and have hemoglobin levels that are almost in the normal range. So to summarize gene therapy, keep in mind this does require a bone marrow transplant, but this is one's own bone marrow, so you don't require a donor, you don't require a matched donor in order to do this. Individuals in large proportion have achieved transfusion independence in studies with both beta 0 as well as non-beta 0 genotypes. No deaths have occurred in these trials as of yet, and we hope none will occur moving forward as well. Most of the toxicities were associated with the transplant process itself. So because of the chemotherapy, you may have complications related to that itself. Sometimes during the transplant process, individuals might develop a fever, an infection. So all of those were the major complications that were seen. And again, not all patients have the same response. So you saw from the different hemoglobin levels that they had at the end of the therapy that there may be some variability in that, and some may become transfusion independent, and others may have a reduction in transfusion requirement as well. Maybe some pre-existing conditions that individuals have may play a role. So this is something that we are still looking into very carefully to see why some patients do better than others. And so this might have something to do with the pre-existing conditions that individuals may have in terms of their iron overload, in terms of their liver function or kidney function, and so on. It is a very expensive treatment, and the availability to patients does need to be addressed on a broader scale as well. So this is not yet approved in the US. The gene therapy from Bluebird is approved in Europe for patients with non-beta 0 thalassemia who are on regular blood transfusions as well. But in the US at least, it's not yet been approved. So that's gene therapy in a nutshell. And then I'll just very briefly mention these other new therapies. These are in very early stages of development. So we looked at the way that luspatercept improves red cell production by reducing, by removing that block in maturation. But what has also been targeted is to try and see if we can reduce the dysfunction in those precursors themselves, allowing them to mature better and come out of the bone marrow as functional red blood cells. So one of the ways in which you can do that is to improve energy metabolism in those cells. And so those cells are able to utilize energy better and therefore may not die in the bone marrow itself. And so there are two approaches to that. One is to activate the pyruvate kinase enzyme, which is an enzyme that allows the red blood cell to metabolize glucose for energy. And there are two drugs there. One is called mitapivat, and the other one is called FT4202 from different companies. You can also inhibit something called phosphodiesterase 9. That is one of the enzymes that is responsible for energy metabolism as well. And so you can modify that, and that might have an effect as well. We have some proof of principle in the pyruvate kinase area. Both of these companies have shown some preliminary data showing that this does improve the output of red blood cells from the bone marrow. And so the hope is that, again, as with luspatercept, you might have a reduction in transfusion requirement in transfusion-dependent individuals and higher hemoglobin levels in non-transfusion dependent individuals. But again, these are clinical trials that are barely underway, and so we'll have to wait a little while to get results from them. The other thing I'll just mention very, very briefly is an agent called hepcidin. Hepcidin is normally made in your body and is responsible for making sure that the iron that you have is kept safe inside storage organs. And in individuals with thalassemia, the hepcidin levels tend to be on the lower side as a function of their iron overload. And what they've tried to do is to try and see if giving hepcidin from the outside can actually improve both the iron overload. And so there was the study down here, La Jolla conducted to see if it could reduce iron in the heart. And unfortunately, this study did not show a positive outcome and was terminated. What they're still doing is to look at this other agent, PTG300, to see whether or not the bone marrow precursors can be affected by giving hepcidin, and they can again mature more effectively to produce more red blood cells. So the goal here is to see again if you can reduce transfusion requirement in transfusion-dependent individuals and increase hemoglobin levels in non-transfusion-dependent individuals. And these are still very, very early. So what I've tried to do is to give you sort of an overview of therapies that are more advanced in terms of their clinical trials. One obviously is already approved, and then gene therapy is coming. It's in the pipeline. Some mechanisms are a little bit more advanced than others. And then you have these other therapies, which are drug therapies, which are still in early clinical trials. So I'm going to stop there. This was a lot of information to provide in a short time. I'm happy to explain more as well as answer questions as well.
Great. Thank you, Dr. Sheth. Excellent presentation. We don't have a lot of time, but let's do answer a few questions while we can. I'm going to combine two of our questions. This is about alpha thalassemia major. Someone was wondering, does gene therapy or gene editing apply to alpha thalassemia major patients if they were considered in the future? And also, Reblozyl was approved for beta thalassemia patients. Would it also be available for alpha thalassemia major patients who are treated clinically like beta major?
So that's an excellent question. So far, the alpha thalassemia individuals were not included in either the luspatercept trials or the gene therapy trials. Now, the gene therapy is very specific so far for individuals who have beta mutations because it does not address alpha mutations at all. So the current gene therapy and gene editing would not be applicable to alpha thalassemia. We don't really have a sense of what luspatercept would do for alpha thalassemia because the studies were not actually done in them. But we do have some data from the Agios drug, the mitapivat that I mentioned in the last slide, that shows that alpha thalassemia affected individuals may also show a response to that drug. So if you say that you can improve the hemoglobin levels in individuals with alpha thalassemia, so that's usually individuals with hemoglobin H disease, then you might be able to have the same effect with some of the other agents that might affect maturation in the bone marrow as well. So more to come on that, but at least from the standpoint of mitapivat, we do have some data that shows that it is effective in individuals with alpha thalassemia as well.
Thank you. Our next question asks, does the effectiveness of Reblozyl depend on pre-transfusion hemoglobin, for example, if it was only a 5 or 6? And also, does it have any effect on white blood cell counts?
So far as we know, it doesn't have any effect on white blood cell counts. The white blood cell counts may be elevated because your bone marrow as a whole is so revved up. And so maybe if your bone marrow was a little bit more effective in terms of its output, that it would not be as revved up as a whole, and maybe that would result in a reduction in the white blood cell count as well. We haven't seen that effect yet. I don't recall the data from the phase 2 study for Reblozyl as of yet. And no, we've seen responses in individuals whose hemoglobin levels have been. So again, we don't have a whole lot of data in non-transfusion dependent individuals. So if your hemoglobin is 5 or 6 at baseline without transfusions, then we don't have a whole lot of data in those individuals. But we do know that from the phase 2 studies, the earlier studies, that individuals with non-transfusion dependent thalassemia who got luspatercept did respond with increasing hemoglobin levels. So that is something, we will get a lot more data on a lot more patients from the currently ongoing study in non-transfusion dependent individuals as well, to see whether or not individuals whose hemoglobin levels are lower is better or not as well with luspatercept. So more to come on that in the non-transfusion dependent individuals. But we do know that if you are transfusion independent, if your baseline hemoglobin prior to starting transfusions was 5 or 6 or 7 or 8, it doesn't really make that much of a difference. You can still have a response to luspatercept. So that's the difference between individuals with beta 0 and individuals with beta 0 beta plus or beta plus thalassemia as well.
Thank you. And is there a disadvantage of fetal hemoglobin in comparison to normal adult hemoglobin?
That is an excellent question, and we don't really have an answer to that, a definitive answer to that. So far, the 2 individuals who were treated with the gene editing protocol have not shown any side effects from having predominantly fetal hemoglobin compared to adult hemoglobin. But again, this is something that we'll really have to look at long term, because the one thing that fetal hemoglobin does is it hangs on to oxygen more tightly than hemoglobin A does, and so it doesn't give it up as easily. So, are we going to see any effect from that down the road? I don't know as of yet what happens if somebody has 90% or 95% fetal hemoglobin. We do know that individuals who have 30 or 40 or 50% fetal hemoglobin do just fine. And they don't really have any major effects from having a high amount of fetal hemoglobin compared with hemoglobin A. But we don't know when we get up to the sort of 90% range.
Thank you. You mentioned that some patients develop blood clots while on Reblozyl. Do you know if there was a common denominator in those patients and how far into the treatment the blood clots developed?
So most of those patients had, as I said, other risk factors as well. So the other risk factors included having had a splenectomy and having very high platelet counts, having or being smokers, being on oral contraceptive pills, having a past history of vascular disease and thrombosis as well. And they didn't develop at any specific point in the treatment regimen. They developed at various time points. Some of them were very, very mild in terms of superficial thrombosis and thrombophlebitis, but there were a couple of individuals who had more severe or more significant thromboses as well. But it can happen at any point in time.
Thank you. Are you able to offer an opinion as to what the pros and cons are between gene addition therapy and gene editing therapy?
I think the gene editing is still very early in terms of, again, as I said, we don't know what the effect of having, 95% fetal hemoglobin will be in the long term. The difference is primarily that, the gene addition requires a viral vector. And initially, at least, there was a huge amount of concern that having a viral vector and the viral genome integrating into the stem cell genome, that might cause some risk. And you might worry about having things like the development of cancers and stuff like that. So far, it doesn't seem like that is a concern at this point, because the genome of the virus integrates at very different points in the genome of the stem cell. So it doesn't seem like that's going to be a major problem. But again, we don't have a whole lot of long-term data on the individuals who have undergone gene editing as of yet. We only have a lot of data on gene addition. So it's still, I think, very early to say whether or not there'll be anything different. Most of the complications we've seen so far have been related to the transplant procedure itself. And those are quite similar in both groups, the gene addition group as well as the gene editing group.
Thank you. This is a question that requires you to, be more than just a doctor. Do you think that luspatercept will be considered for pediatric patients if the blood supply gets diminished due to the pandemic, if there is a big blood shortage?
So it's very hard to say whether or not an insurance company will approve it for what we would call compassionate use. At this point, any therapy that is not approved by the FDA, if you want to use it, it's either an off-label use and requires you to get compassionate approval. So sometimes it requires you going through an IRB process to say we want to use a drug that has not been approved specifically for this particular patient population. So I'm hoping that we don't really get to that point where we need to consider all of these options, because I would be hesitant not knowing what kinds of effects you might see in children that might be different than what you've seen in adults. So I wouldn't be too keen to start to use it unless you're really pushed to the wall and did not have any ability to get blood for these individuals.
Thank you. And this will probably need to be our final question. Are there any gene therapies, including gene editing, that don't require chemotherapy, and why is it necessary for gene therapy?
So as I showed, what you're doing with this is you're removing stem cells from the individual, and these are being either the gene is being added or it's being edited outside in a laboratory, right? And then these modified cells are being put into the body. Now, if your body does not accept these cells as readily and allow them to go to the bone marrow and set up, their homes there and start to make cells, then they won't be effective. And so what we need to do for that is to be able to create some space in the bone marrow, and therefore you have to be able to, in some way, reduce the amount of bone marrow that an individual has to be able to create this space for the for the modified cells to go in and find their homes there. And that is why you have to give the chemotherapy. The hope is that eventually we will be so technologically advanced that we will be able to do the editing or the addition that currently happens in a laboratory. We'll be able to do that in the human body itself. We'll be able to give you an injection of something or do something that is able to do the editing in the or addition in the body itself, in your stem cells while they're still in your bone marrow. But that is still a little ways off because technology is not yet quite that advanced. But again, one can hope, and with the way that we are getting better and better technologically, that this is something that will come to be a reality as well. But right now, no, you do need to need to undergo the transplant, and you do need to get chemotherapy to be able to make the space.
Thank you, Dr. Sheth, for an excellent presentation and for fielding those questions so well. We appreciate you spending time with us today. And I'd like to thank everyone for joining us on the online conference today. It's been a pleasure to bring this information to you. We hope that you have found it valuable and an effective stopgap for not being able to have an in-person conference this year. We hope that you will fill out the survey, which is on the app, just to let us know what we did well and what we need to do better the next time that we're doing something like this online. The app will be up for about the next 30 days, so that if you want to download things from there or revisit things, you've got time to do that. And we hope that we'll see a lot of you joining us on our Care Walk on September 20th. Please feel free to contact the office. You can contact directly Mary Wolde-Jorgis. That would be Mary, M-A-R-Y, at thalassemia.org for more information about the Care Walk. And until next year in New Brunswick, July 9th through July 11th, hopefully in person, we hope everyone stays strong and stays healthy. Thank you and good night.